I'm Dr. Kathy Sheppard-Jones with the University of Kentucky's Human Development Institute. We are one of the university's centers and institutes and are under the office of the Vice President for Research. Though we aren't within a college at the University of Kentucky, we work across colleges and units in our mission to promote the inclusion, independence, and contributions of people with disabilities and their families throughout the lifespan. We accomplish this mission through education, research and evaluation, information sharing, leadership, and advocacy across Kentucky and the nation. And today I want to talk about health equity and what that means about access to health care for people with disabilities. Health equity and health disparities are issues that are at the forefront of our thinking more than ever in the current climate of COVID-19. So today I'm going to set the stage by providing some statistics about disability in Kentucky. I will also provide some of the key issues that are being discussed right now in Kentucky and the nation. And next, I will be sharing some ideas and wrap it up with resources that hopefully will be of benefit to you all in the work that you're doing. So to start off, we need to find some common ground and a frame of reference when we're defining what disability is in the first place. The Centers for Disease Control and Prevention, or CDC, has a very nice definition of disability. A disability is any condition of the body or mind that makes it more difficult for the person to do certain activities and to interact with the world around them. In other words, the person has an impairment leading to limitations in activity and restricts full participation. Now, the World Health Organization further breaks out the disability definition and expands on it for us. In this definition, impairment is considered a body structure, function, or mental function. Activity is the execution of a task or action by a person, and activity limitations are things like difficulty in seeing, hearing, walking, problem solving. Now, participation restrictions are those life domains that include things like working, engaging in recreation, accessing healthcare. So participation here represents a person's involvement in a life situation. Now, it's also wise to look at disability from a legal perspective. And the Americans with Disabilities Act, also known as the ADA, is an anti-discrimination law that was signed by George W. Bush back in 1990. Now, the ADA follows in the path that was forged by the Civil Rights Act of 1964 with the intent of providing equal access and equal opportunity in employment, in purchasing goods and services, in state and local programs and services, and in telecommunications. There's also a miscellaneous title within the ADA. To be covered under the ADA, someone has a disability when that person has a physical or mental impairment that substantially limits one or more life activities. Now, the person could also have a record of such an impairment, and that could be something like cancer, or if the person is regarded by others as having a disability. Now, in this situation, it could be a person who perhaps has facial scars that may result from burns, but who doesn't actually have any limitations to major life activities. The fact that other people perceive the person as having a disability is what would mean that the person is actually covered under the Americans with Disabilities Act here. And I think that's an important distinction. Now, under the ADA, major life activities cover a lot of areas, and those include caring for oneself, performing manual tasks, seeing, hearing, breathing, eating, sleeping, walking, standing, lifting, bending, speaking, learning, reading, concentrating, thinking, communicating, working, and operations of a major bodily function. Now, bodily functions include normal cell growth, immune response, digestion, bowel and bladder, neurologic, brain, respiratory, endocrine, circulatory, and reproductive functions. So I think you can certainly see here that major life activities really are intended to reflect a broad array of domains. Now, the very last definition of disability that I want to share with you is one that defines disability using a social model. And in this way, disability is thought of really as a collection of conditions that are actually created by society. Now, this might seem a little bit odd to you, but when we use this model, we're recognizing that people have physical or mental impairments, but they're not actually considered to be disabled until society makes them so. So my best example here is going to be by saying that I have always had a mobility impairment. I use a wheelchair for mobility, but I didn't actually connect to the fact that I had a disability until I got stuck in a snowbank on an unshoveled section of sidewalk on a college campus in Vermont back in the dead of winter when I was a freshman. I don't find that I'm disabled at work unless I have to go into a building that doesn't have a ramp, or I go to a meeting where I may not be considered an equal among my peers. On those days, I say those are my disability days that I'm experiencing. All right, so we've defined it. Now let's apply some data that is of interest to us. Now we know that disability affects all of us. And in fact, 25.6% of adults have some kind of a disability in the United States, and that's highest in the South. And in our state of Kentucky, our Commonwealth of Kentucky, actually, it's about 34.6%. And what this means is that if you don't have a disability, people in your family do, as do your friends. You are therefore knowing and loving people with disabilities. And if you don't have a disability now, the chances are that because of changes in technology and medical advancements, you may acquire a disability as you age. Disability really is just part of the human experience. And one in the research that we do, I utilize disability variable as a demographic variable. Now, there are, however, some important health disparities or differences in health outcomes between people with and without disabilities that certainly do exist. So let's talk about some of these disparities that we find in Kentucky. And the first is that nearly half of Kentuckians with disabilities are inactive versus roughly 30% of Kentuckians who do not have disabilities. Kentuckians are more likely to smoke, whether one has a disability or doesn't have a disability. But like the previous statistics, if the person has a disability, these negative health outcomes are actually higher. And the bad news just sort of keeps on coming. About 42% of adults with disabilities are more likely to have high blood pressure nationally, as opposed to 25.9% of those without disabilities. And in Kentucky, that escalates up to almost 49% of adults with disabilities having high blood pressure versus about 30% of non-disabled adults in Kentucky. And that's huge. We also know that adults with disabilities are more likely to be obese, and 42.8% of Kentucky adults with disabilities are obese versus 29.5% of those without disabilities. So those disparities are important, those comorbidities, in fact, that we'll talk about later when we explore some of the COVID-19 relationships also, I think, as you all know, really do come into play. Now here in Kentucky, we also find higher proportions of people with mobility and cognitive impairments, along with independent living disabilities. Along with that are those who have vision and self-care disabilities as well. And really all of this fits, given that Kentucky does have the highest proportion of people with disabilities in general for the nation. So we're number one there. And if we further break down disability by type, roughly 1 in 6 people with a disability have what's called a developmental disability. And as that's defined by the Developmental Disabilities Assistance and Bill of Rights Act of 2000, also known as Public Law 106-402, the term developmental disability means a severe chronic disability of an individual that is attributable to a mental or physical impairment or a combination of mental and physical impairments. It is manifested before the person reaches the age of 22. It results in substantial functional limitations in 3 or more of the following areas of major life activity. And these include self-care, receptive and expressive language, learning, mobility, self-direction, capacity for independent living, and economic self-sufficiency. Additionally, a developmental disability reflects a need that a person has for a combination and sequence of special, interdisciplinary, or generic care, treatment, or other services that are lifelong or expected to be of extended duration, and that are individually planned and coordinated. Based on this definition, it's important to talk about what could make the experience of COVID-19 different for people who have developmental disabilities. As I described, there are large proportions of people who experience these secondary or comorbidities like obesity. And many individuals also have communication differences. Some individuals may possibly use home ventilators as well. The self-care aspect of developmental disabilities also means that a person with a developmental disability may not live completely independently, but rely on a family or paid caregiver for activities of daily living. And it's also notable that thousands of Kentuckians live in environments that would put them at higher risk for exposure to COVID-19 because they reside in group home settings that have paid caregivers, resulting in what turn out to be unavoidable exposure to more people, and therefore they have a more difficult time in the ability to follow those social distancing guidelines. Along with this, communication differences may also lead to inequities in healthcare treatment, and we'll talk more about that later. So, ultimately, I think it's important to know that developmental disabilities really reflect a variety of disabilities, and these can include intellectual disabilities, cerebral palsy, spina bifida, traumatic brain injuries that happen while meeting the age guidelines as well. A person with a spinal cord injury that is obtained within the same developmental period also could be considered to have a developmental disability. And with respect to COVID-19, there has long been, for as long as we can consider, the last several months long, there's discussion around the at-risk groups. And so data is starting to come in around other demographic information as well about race and some about disability status. And we're starting to get a sense that some of the federal data is indicating that hospitalizations are reflecting Black patients are disproportionately highly affected. In the CDC's Morbidity and Mortality Weekly Report, the MMWR, from April 3rd, health conditions among patients with coronavirus that were reported between February 12th and March 28th were reviewed. And our U.S. data showed that people with underlying health conditions such as cardiovascular disease, lung disease, renal disease, those who are immunocompromised or who have diabetes are at higher risk for severe COVID-19 than those without. The data also looked at some other disabilities, and of the 75,000 cases or so that had data to review, it was reported in the MMWR data that less than 1% had a neurodevelopmental or intellectual disability. So this first initial analysis of cases, as was shared by the AADMD, showed that we're not seeing people with developmental or intellectual disabilities being overrepresented, at least at this point. So I think that that's noteworthy for sure. And let me also tell you, I know I just threw an acronym at you, and that AADMD stands for the American Academy of Developmental Medicine and Dentistry. So let's talk about some other data that's particularly salient right now, and that is around that need for ventilators. In Kentucky, projections made about numbers that result from predictive models are varying, and that matches up with what we're seeing, right? There's a lot of different modeling that's going on. If we were to consider a population of roughly 4.5 million in Kentucky, calculate a 3% infection rate, that would mean that about 135,000 Kentuckians would experience COVID-19. If 5% of those people who became infected subsequently needed ventilators, now we're talking about 5,150 people. Now, of course, we wouldn't expect everyone to need them at the same time, but based on the current numbers of ventilators that are available, if the need for ventilators outstrips the availability based on population, really difficult decisions are going to have to be made. So that really, I think, sets the stage for us in terms of talking about what does this mean for Kentucky in light of the coronavirus, and specifically right now, here in 2020. Because since this winter, we've seen how COVID-19 has changed our world. Our lives have undergone tremendous shifts over the last few months, and we're learning how to live in this new normal right now as the pandemic and worldwide crisis is impacting people in all parts of the globe. And we need to consider the rights of people with disabilities in healthcare and better understand some of the critical issues while seeking to ensure that disability discrimination isn't happening. So equitable care and treatment in healthcare has always been critical and a right. But now, inequitable care can result in some horrifically bad outcomes for people with disabilities, including death. And there are many points in the continuum of care that can interrupt services for people with disabilities for a lot of reasons. And we expect that COVID-19 is going to be disrupting services. You know, we're seeing programming shut down. We're seeing disruption of services and resources within the healthcare system itself. And we also see that states are really trying to access much needed resources, desperately needed resources, including personal protective equipment or PPE and ventilators, recognizing that the nature of COVID-19 in causing major respiratory compromise. So while we're still learning a whole lot in a very short amount of time, in many ways, we've really been unprepared for this once-in-a-lifetime pandemic, and the way that our society responds to it and determines how scant supplies are allocated has the potential to put the healthcare system in the unenviable position of having to make these life or death decisions. Now, as has been recently reported in a Kentucky newspaper, the Paintsville Herald, one of the biggest fears for Johnson County resident Natasha Miller, whose 14-year-old son Isaac has Naegger syndrome, which is a rare condition affecting development of his face, hands, and arms. She said she has to be extra careful about exposing him to viruses. And she said in this interview, when the school shut down, it was scary. When I started hearing how this affected New York, immediately it wasn't, I need to protect my family. As selfish and terrible as this sounds, and I feel bad for even saying it, it was, I need to protect Isaac because it's a death sentence for him. He's looked at as critical. How hard would they fight would they just give up? She's talked about stories she's seen where doctors and nurses in hard-hit places are having to choose the people they can help. It makes her worry that if there's a shortage of supplies here, her son would be one of those who wouldn't get the help that he needs. So to that end, on March 28th, the Office for Civil Rights at the U.S. Department of Health and Human Services provided a reminder to everyone that during this pandemic, all of the protections that are provided under laws like the Americans with Disabilities Act, the Affordable Care Act, and Section 504 of the Rehabilitation Act still apply. And specifically, this means Titles 2 and 3 of the ADA apply. Title 2 prohibits discrimination by local and state government agencies. Title 3 prohibits discrimination by private healthcare providers. Now, Section 504 of the Rehabilitation Act prohibits discrimination by recipients of federal financial assistance, and Section 50 and 57 of the Affordable Care Act prohibits health care programs that receive federal funds or that are operated under federal programs from discriminating. The bulletin that came out is an attempt to help ease concerns for families like the one that I shared. And these have been rising in the disability community and are also in response to some states' actions that could be interpreted as possibly out of sync with these aforementioned laws. So the guidance is there to help ensure that people with disabilities don't have to worry about being denied medical care on the basis of stereotypes, assessments of quality of life, or judgments about a person's value or worth based on not having or having a disability. And that is directly coming from the bulletin. And I was on a call recently, and the director of OCR, Roger Severino, indicated that it was imperative for OCR to put out this guidance during this time. And he really made a passionate plea about this because of his concerns and ensuring that states and providers remember where the guardrails are so that we don't lose sight of our humanity. And those are his direct words, and I think they're extremely powerful. We don't want anyone in healthcare to be put in the position where they're making a decision about providing care in the moment because there's not a process in place. So the OCR guidance gives flexibility, but promotes states developing principles in the decision-making process on the front end instead of doing so on the fly. And to that end, OCR is requesting complaints be submitted to their office at hhs.gov/OCR. And I just want to take a few minutes to share some details about complaints with you all to give you a sense of some of the current situations that are going on around the country related to those difficult situations and around crisis standards of care and concerns from those with disabilities and their families. So in Washington State, protocols specifically recommend that in the event of shortage of resources, that people with disabilities be transferred to receiving palliative care. And when making these determinations, the state was assessing a person's baseline functional status and assessing pre-existing conditions. And in order to maximize overall survival, they're making judgments about long-term survival, beyond survival through treatment. And in this case, their priority was on those who were young and healthy. So that was the judgment call that's being made there. In Alabama, in regard to triage and use of vents, the crisis of care indicates that hospitals shouldn't consider people who have severe or profound intellectual disabilities. Remember, that's a type of developmental disability as well, as they would consider those individuals as, quote, unlikely candidates for ventilator support. In the state of Kansas, they developed a toolkit for COVID-19 indicating that they would potentially take ventilators away from people with disabilities who use them as part of their ongoing care, signaling that they could potentially take them away to use on a higher priority person. So what we're talking about here isn't someone about making the decision of whether or not that someone should have access to a ventilator. what was being said in Kansas was that, well, no, actually, we might come and take your ventilator away to give it to someone else. In Tennessee, those with neuromuscular diseases, including spinal muscular atrophy, who need help with activities of daily living, would be excluded from receiving care in the event of shortage as well. So there's a lot of different examples here, but I think this just really emphasizes the importance of the OCR guidance in reminding everyone that the laws still apply both in times of peace and in times of crisis. Now is just such a time when there's fear among people with disabilities and caregivers, and just so much concern that's being expressed all around the country. There are concerns about reallocation of resources, particularly given the focus on ventilators. Quality of life judgments are being made that slant toward ableism. One legal scholar recently wrote that a lottery system would actually be more fair in determining course of treatment than having a medical professional factor in disability when triaging. And I think that should be enough to give us all a little bit of pause. The OCR guidance gives us a framework to use to include individuals in the COVID-19 response and tries to help slow the individual healthcare decision-making that's focusing on assessing quality of life and the unconscious biases that go along with that. What I mean here is that people are making assumptions about quality of life that must automatically be worse when one lives with a disability than if one does not. So really, who's best suited to make that call related to quality of life? Healthcare has long been conditioned to assume that quality of life, or the person whose life is actually being measured. There's lots of philosophical questions and debate that comes into play here, because even if a person with a disability is deemed to have a lower quality of life, then can we say, well, that happens because of a lack of opportunity provided by society? It's not all on healthcare. Inequities for people with disabilities exist in employment, education, community participation, and access to virtually all facets of life. Even if decisions are made based on life expectancy, we know that physicians haven't received enough training, in particular around intellectual and developmental disabilities, to be able to adequately predict a person's length of life. And therefore, that's not a solid technique to be using. And really, the complaints that I shared with you are part of a longer history of discrimination that's faced by people with disabilities, including lack of physical accessibility, lack of accessible communication, and overall lack of access. So all of these things lead to health disparities. So let's flip it a little bit. Let's spend some time now talking about communication and accommodations for people with disabilities in healthcare. And let's start with communication, because oftentimes communication winds up presenting barriers that are either actually perceived barriers, if we're again making assumptions about a person's capabilities, or true barriers if we're unable to identify strategies of how to address them. So people who have disabilities related to vision, hearing, or speech are going to use different ways to communicate from the person with whom they're communicating, potentially. So someone who is blind will likely be providing information audibly instead of writing. A deaf person may not use speech, but instead use American Sign Language or write the information down. Alternately, a person might use what's called an augmentative communication device to speak for them. So ultimately, when we're talking about communication problems, it happens when the reception and expression styles are different of the receiver of information and the conveyor of that information. So the Americans with Disabilities Act, again, see, aren't you glad that we talked about what those titles are and how that is involved? Because it really does come into play in a variety of ways for us. The ADA requires that state and local governments and businesses and nonprofits that serve the public communicate effectively with people who have communication disabilities. The goal here is ensuring that communication with a person with disabilities is going to be as effective as communicating with someone without disabilities. Regardless of how that person communicates, we do know that there are best practices in communicating and accommodating. So let's talk a little bit about those. So when you're communicating with a person with disabilities, first and foremost, talk to the person directly. The most obvious scenario here is one in which a deaf person is communicating with an interpreter. Don't speak to the interpreter, speak to the person. Other scenarios may not be as obvious here, but don't make assumptions about a person's ability to communicate. Just because a person happens to have a disability does not mean that the person is unable to speak for themselves or to be able to understand. So that really leads to the second point, which is to ask the person's permission before speaking with caregivers. And it's okay to ask for help if you're having difficulty in communicating with a patient, but don't make this the starting point. Your first point of communication is with the individual, with the patient. To that end, and it holds true for all interactions with people who are not your professional peers, use plain language. Avoid that jargon and those complex terms and phrases. Communicating about healthcare issues in a crisis situation is emotionally charged as it is, and plain language can help you convey information. You serve a diverse population. That includes people with differing educational, work, and life experiences, and when you use plain language, words are simplified and clearer regardless of that background of that person. And about 20% of adults in the U.S. are unable to read a newspaper. And plain language uses words that are typically between a third and a fifth grade reading level. A newspaper is between fifth and sixth grade. So the next communication point to keep in mind is that although you may be having difficulty understanding the patient, in most cases, you should know that they understand you. And I mentioned this before, but it's worth repeating because time is really at a premium. And I get that, but you need to find ways to provide the time that's necessary for patients to speak, to respond, and to understand what you're saying. If a person's difficult to understand, it's okay to ask that they repeat themselves. What's not okay is to cut people off because it takes them longer to express themselves or to indicate that you know what they said, even if you actually don't. So now let's talk specifically about accommodations. The ADA requires accommodations be made in order to provide appropriate services for people with disabilities. And some examples in healthcare-related accommodations would be allowing a caregiver to go with a patient to ensure that there is adequate support for decision-making and treatment. Hospital policies have changed for safety reasons regarding visitors. We know that. However, in some cases, an accommodation here is necessary so that the patient with a disability who needs help in communicating, advocating, understanding, or in their self-care gets what they need. Another accommodation is to provide adequate physical access to medical services. So this issue is one of accessibility and usability. So examination rooms that are large enough to fit the provider and the person who is utilizing a mobility device like a wheelchair. It also means having entrances that are accessible, providing adequate clear space to get into the building with ramps. It also means ensuring that a person with a disability has accessible parking with access aisles in the parking lot that enable the person to get from their vehicle to the building. Other accommodations come back to those things that I mentioned before around communication, such as providing interpreter services for those who need them and for being cognizant of communication needs as they arise, and providing information in a variety of ways, such as pictures or icons for people who may have limited verbal communication. Now I want to talk a little bit about best practice. Ideally, right now, people with disabilities are increasing their health literacy around COVID-19, just like all people are, and recognizing that health behaviors that are preventative and will help to ensure that they're able to avoid infection altogether. That's what we're after with the entire population. And as such, that means that we need to make sure that people with disabilities are being considered in all of the healthcare messaging that's done. Preventing infection through good hand hygiene, household cleanliness, social distancing, and the AADMD, remember the American Academy of Developmental Medicine and Dentistry, they're making some good advice available, and their website has some great COVID-19 information. They recommend that people with disabilities have a 90-day supply of medications and medical equipment that they need, and that it's even more important for people with developmental and intellectual disabilities to be prepared for different possible scenarios, just like everyone's doing right now. Along these lines, and from the very outset, we must make sure that key medical personnel are immediately aware that people with disabilities have equal rights to COVID-19 testing and treatment, period. We don't want to further exacerbate the potential of a bad outcome by making an incorrect assumption. It's important to not consider the presence or absence of a particular disease or diagnosis as a mechanism for screening out a person from receiving treatment. Treatment should not be denied based upon presence of a disability. There are people with cystic fibrosis who have good lung capacity. And again, I know I keep talking about assumptions, but this is where assumptions about disability and quality of life can lead to making bad decisions about who is getting treatment. So we've got to make equitable decisions and ensure the allocation of resources and supplies and care and treatment aren't being made based on those assumptions about what it is like to live with a disability. So as I've also mentioned, go ahead and provide accommodations to make sure that everyone has access to what they need for testing and treatment. Accommodations include those for all kinds of disabilities that may impact a person's ability to comply during testing and treatment as well. Right now, by really assessing the capacity of the healthcare system as a whole, we need to think about this time in history and take a longer view of these issues and what they mean as a society in terms of where we want to be. What are our values? How do we invest in preparation for these catastrophic possibilities? All of these decisions have repercussions for people with disabilities, and as we're seeing, lack of investment can mean the difference between life and death. And there are people who are afraid that a ventilator-dependent person who seeks treatment may, in fact, not only be turned away for treatment, but may lose that ventilator as well if there's a lack of supply. And if treatment avoidant behaviors are happening, then disproportionate deaths will surely follow. In a recent guidance to state hospitals document, Principles for Avoiding Disability Discrimination and Treatment Rationing specifically address this idea that physicians and triage teams must not reallocate ventilators that belong to people with disabilities who are using them in their daily lives. And really, by taking sort of this longer term or broader view, we're also considering the needed investment in training on disabilities for medical professionals. I've talked a lot about assumptions. Education can help eradicate the need for making one's own best guess. And as I also mentioned in the data section earlier, with 26% of the population having a disability and roughly 1 in 6 people with disabilities having a developmental disability, the American Medical Association currently has no training standard on developmental disabilities for physicians at all levels of training. There's a need to better understand developmental disabilities in particular in medical education. So that's food for thought, something that we need to think about. Something else we need to think about is how people with disabilities are represented in our healthcare system as a whole. Do people with disabilities sit on your ethics team? Are people with disabilities supported as students, as residents, as medical professionals in your organization, as support professionals? If 1/3 of Kentuckians have a disability, how well does your team reflect those who you are serving? We want to ensure that we get through this crisis together, and that means taking stock of areas where we may be missing the mark. Data is coming out that shows disparities in racial outcomes related to the pandemic. We're also seeing data around those with underlying conditions, disability organizations coming together at the state and national level, along with self-advocates and family members to help ensure that disability discrimination doesn't occur. we want to learn from COVID-19. There's true anxiety for people with disabilities and for families of people with disabilities and for people who love and care about people with disabilities. The healthcare system is being tested to the extreme right now. There's so much uncertainty in all aspects of life for everyone that access to good information, the ability to be flexible, use accommodations as much as possible, and work in concert with each other is going to help us all to learn, grow, and continue using the innovations and the skills that we're gaining when we come out on the other side of this together. So I'm going to leave you today with some resources that'll hopefully be of help. And I want to thank you so very much for the opportunity to talk with you about health equity and disability in the face of COVID-19. So I wish you well and stay connected. Thank you.